A new year doesn't have to mean doing more. It can mean knowing where to focus. When you understand which habits genuinely protect your heart, strengthen your bones, support your hormones, and improve your overall well-being during menopause, it becomes much easier to make choices that add up over time. Today's episode brings together clear, expert guidance to help you step into 2026 feeling informed, capable, and supported in your health decisions. Welcome to All About You. I'm Dr. Shauna Watts, GP and women's health advocate. Every week, I bring you evidence-based conversations to help you understand what's happening in your body during midlife and how to support your health in ways that are practical, realistic, and sustainable. In today's episode, we're bringing together some of the most valuable expert advice to help you start 2026 strong, not through extreme resolutions, but through informed, achievable choices that genuinely protect your long-term health. By the end of this episode, I hope you'll understand the lifestyle changes that make the biggest difference to heart health during menopause, what types of exercise best support your cardiovascular system in midlife, the key risk factors for osteoporosis, and what you can do now to protect your bones, how alcohol impacts sleep, mood, and hormones during menopause, and why sexual health and sexual longevity deserve a place in conversations about healthy aging. You'll be hearing from Associate Professor in Cardiology, Dr. Tom Ford, GP with a special interest in menopause, Dr. Alison Mooney, alcohol coach Sarah Rusbatch, and regenerative and longevity physician Dr. Amy Killen. This information is general in nature and not intended to replace personalised medical advice. Always consult with your healthcare provider regarding your specific situation. If you could give people some tips of things that they could easily change in their lifestyle that will make a big difference to their heart health, what would they be?
The lifestyle factors is movement, right? It's trying to find an activity that we know, and this is not just for the risk of heart attacks, but it's to continue aging well, right? It treats a lot of things. So a regular form of physical exercise that has to be sustainable, whether that means doing it with friends or perhaps some social connection with that exercise, I think that would be a really good thing. And then in terms of the diet, I think sometimes we see people go overboard, don't we? And we can take the diet kind of too seriously, but my feeling is that diet is very important, but up until a point, and we've got to have the right balance, right? And so red meat, for example, in my diet, I would have red meat probably 2 to 3 times a week, and I don't feel guilty when I have that. I enjoy it, but I think to balance that out, I like to have, a lot of vegetables and, high fiber vegetables, green leafy vegetables, and liberal use of kind of good fats, things like legumes and olive oil, avocados. So that type of thing will boost the HDL and I think give you a bit of balance. The other thing that maybe not many of us eat enough of is oily fish. So 2 to 3 times a week. Salmon's quite heavy, isn't it? But, we live in a country with amazing seafood. So, barramundi and fish, I think, should be a regular feature on our dinner plates.
In terms of supplements for the heart, are there any sort of vitamins or minerals that people seem to be deficient in that seem to play a part in heart health?
No, I would say in general terms, if we've got a good diet, there shouldn't be too much need to supplement it. We do see that there's a lot of patients that take supplements, and if they feel better for taking it, I'm happy for that to continue. My own feeling is perhaps they might be overused, and I've seen some patients recently that have actually come into a bit of trouble from too many supplements, including some kind of elite level athletes and things like that had, toxicity from different vitamins. But the things that would be maybe under used, perhaps vitamin D would be a good example of one that, as Australians, the sun's so strong. My skin's taking a beating out here, but vitamin D is probably a good thing to replace. Something that we would often stop is calcium supplements, because we do think that if you've got a normal non-vegan diet, you get enough calcium, and it can be detrimental in terms of building up into plaques and causing hardening of arteries.
So that's definitely a tricky one, because I definitely see patients who've perhaps seen dietitian or nutritionist, and there's concerns around their bones and maybe having a bit of osteopenia, and they're being told to take calcium supplements, but yet they maybe already have quite a dairy-rich diet. And so you're saying that calcium actually could be a bad supplement to be taking?
Well, we know from good data, looking at, hundreds of thousands of patients, that at a population level, we probably will be doing harm by prescribing, blanket amounts of calcium supplements. But it comes back to the concept of the absolute risk to an individual. The absolute risk is probably quite small, but if we treat enough patients, then that's an important concept to think about. So for me, I'm quite relaxed about stopping the calcium supplements, because I don't think there's a robust, correct me if I'm wrong, I don't think there's a robust data to say, if you take the calcium supplement, you'll have stronger bones and you'll have less osteoporotic fractures. I think, if anything, it's just us wanting to try to be doing something.
Yeah, it's to do something.
Yeah. Yeah.
And obviously smoking has gone out of fashion a lot, but there's definitely still smokers around.
Yeah.
What is it that smoking does to your heart?
So smoking has a number of toxic substances, predominantly that inflame the vessel wall. So if we measure C-reactive protein, which is a bloodstream marker of inflammation, that's definitely higher in smokers. And the first thing that happens is the endothelium, which is that Teflon coating inside the blood vessels, becomes angry and it becomes permeable. So by permeable, we mean that it becomes a bit like a sieve. So the LDL, the cholesterol particles, can diffuse through the lining of the vessel walls and can build up in plaques. And that's what we see in smokers. And I would say that definitely that would be a very important thing to address. And perhaps vaping, of course, it's definitely common.
It's unbelievable, isn't it? I cannot believe how many people vape.
And it probably does some similar things, but probably not quite as bad for you as tobacco.
Yeah. So if you had a patient who you'd seen and they'd had a myocardial infarction or a heart attack, you would be strongly encouraging them to stop vaping like you would have been doing years ago when people were smoking.
Definitely, yeah.
Yeah.
I think it's important to keep people on side, though. You got to kind of understand it from the patient's perspective as well, right? These things are very addictive. I kind of understand addiction quite well. And my own dad, he is a reformed smoker, but still uses nicotine gum. So I still, I understand that from the patient perspective. It's not easy. And I think you have to have sometimes a negotiation of what's the priority for that individual at any one moment in time.
Alcohol and the heart? Talk to me about that.
So alcohol definitely can have risks for heart health. Specific risks would be high blood pressure and an increased risk of arrhythmia. So those would be the two big ones. The arrhythmias that we commonly see in people who use too much alcohol is AF and ectopic beats. But in terms of the arteries, some of your listeners will be pleased to know it's actually not a potent risk factor for blocked artery heart disease. In fact, there's kind of a sort of running joke in a lot of cath labs that in alcoholics' hearts, you just often see these big clear pipes. I don't know the alcohol, but it definitely has hazards for heart, and I think they are well recognized. It can cause a weakening of the heart muscle as well as arrhythmia. But I think, like a lot of things, we've got to have balance, and I'll enjoy a few drinks at the weekend. Just trying to have a few alcohol-free nights a week would be a good approach.
What about like 10 or 15 years ago, or maybe even longer, it became very fashionable for people to drink red wine, and they would tell you that it was for the heart. I did read somewhere recently that apparently the wine industry were very prominent in pushing that narrative as well. I do have patients who, drink a bottle of red wine every night, and they tell me it's for their heart. What do you think about that?
Yeah, it sounds like my dad you're describing. But look, I think probably the data is not very strong. So we try to practice evidence-based practice. And if you just think about the typical person that's drinking red wine, they're people who are probably going to doctor's appointments. They might have a better balanced diet, and they might be a bit more affluent. And therefore, the studies might show that they've got a better outcome in terms of reduced risk of heart disease, but it's because of confounding variables. And it's very difficult to adjust for that. So a short answer is probably, a little bit of alcohol, doesn't really matter what type, is okay. But beyond 2 to 3, maximum of 2 to 3 standard drinks per per one session, and trying to have a few days off a week would be a good tip from me.
Amazing. In terms of, I've had a couple of patients recently who've had myocardial infarctions, and they have been quite depressed after that episode. I think quite scared, quite nervous about doing things, like they know they need to do exercise, but they're quite frightened in case they have another heart attack. And also quite frightened about having an intimate relationship with their partner. Again, very scared, or the partner being very scared. I wonder, could we talk a little bit about that sort of emotional impact of heart disease?
That's huge. It's absolutely massive, isn't it? I think probably it's the most common comorbidity after heart attack. So it's the most common kind of adverse outcome is anxiety and depression. And it's not just for women, right? It's for men, and perhaps women have an advantage that they're naturally often more able to talk about it. And so for my patients, I try and just kind of preempt that and just say, look, it would be almost unheard of for you not to feel real dark days in the months ahead. And there'll be a lot of soul searching after this type of an event. And one of the things that we know through clinical studies improves outcomes is cardiac rehab. And it's run by amazing nurses that live on the Central Coast and do an amazing job. And that really is shown to improve outcomes. And a lot of it is driven by fear, alleviating fear and anxiety. And that actually is important for lots of medical problems, isn't it? It's actually when patients understand what is going on here, it allows you to kind of come to terms with it. And actually a lot of symptoms will reduce. We know that one of the big predictors for bad symptoms is anxiety and depression. So I think if we can address that head on, it's very important.
And can patients safely have sex after they've had a heart attack?
They can do. I think the guidelines to have a couple of weeks off. These days, we typically have complete revascularization. And what that means in plain English is if you've had a heart attack, you've typically either had 1 or 2 blocked arteries or sometimes 3. But we would try and replumb everything so that the patient has no significant residual blockages. And provided they don't have a severely weak heart muscle, I think getting back to these type of activities that give us joy and bring us closer to our loved ones is really important.
What is the connection between osteoporosis and peri and postmenopause? Because it seems to be something that we're all talking about. So would you mind explaining that to the listeners?
All women will reach their peak bone density when they're in sort of their mid-20s, and that's really driven by estrogen. So there's a huge surge of estrogen at puberty, and then that sort of turnover that we talked about is very much more balanced towards building bone rather than taking away bone. So you reach that peak density. After that, it's a sort of very, very slight decline until you hit that 5 years around menopause. And then women can lose between 10 to 20% of their bone density over that 5-year period. And then after that, there's just an ongoing continual decline. So, I think if we see someone in perimenopause, or even before that and they're osteopenic, if you don't do anything at that point, the natural follow on from that is that they will become osteoporotic at some point in the future.
Okay. And so whenever we think about how we would find out if someone has osteopenia or osteoporosis, can you tell us how we do that?
So the easiest way to find out is to have something called a bone density scan, or it's otherwise called a DEXA scan. Anybody can have one. You just have to pay for it, basically, for a lot of women. But you can ask your GP for a referral for a bone density scan. It costs between $100 and $150. And it's a very simple test. It's low radiation. You lie on a bed and an arm just comes over you and measures the bone density at some specific sites. So usually your lower spine and your hips, the top of the long bones in the legs, your femurs, and at your wrist, to give you that score as to whether your bones are normal or they're osteopenic or they're osteoporotic.
And so I know that we have a statistic that 1 in 4 people in the population have osteoporosis over the age of 50.
Mm-hmm.
But the reality is that probably most of them don't actually know that.
Mm-hmm.
And I know that you and I are both very passionate about our peri and menopausal patients, where we have them all trooping off to have their bone density scans. Why do you think that there is a reluctance perhaps for people to have these scans, or do you think that doctors just haven't really been taught to do it, or it's because of whether it's getting a rebate from the government to have it done, or why do you think we're kind of lost our way a little bit with this, haven't we?
Absolutely. Like I think for a lot of women, it's just total lack of awareness. Most of us go about our days today is not really thinking about our bones. We think more about what we look like on the outside and not focus on our skeleton. So yes, the government, I suppose, doesn't make it that easy in that the rebate comes for a funded scan when you turn 70, and we can send anyone for a free scan. But at that point, it's not really become a screening test anymore. It's more picking up disease at that point. I don't know about you, but most 70-year-olds, if it's their first scan, I'd be betting that they were already osteopenic or osteoporotic. The government will fund it for other conditions in women that are under age 70. So, for example, if you have a high risk factor for having osteoporosis, then you will be able to have that funded much earlier. But yeah, I think it's just a complete lack of awareness from patients, but also from doctors, really, to encourage people to go and do it, and the reasons why we want you to do it.
And if we think about those groups who are at increased risk, so our polycystic ovarian syndrome patients who are not having cycles at all, who else are high risk people?
Yeah, so similar to the polycystic ovaries who are not having periods, there's another condition basically that's caused by kind of maybe over exercising and not eating enough. And the first thing that your body switches off is your fertility, so you can stop ovulating. So a lot of athletes might be at high risk of osteopenia and osteoporosis. Then there's other sort of autoimmune conditions like celiac disease, rheumatoid arthritis, thyroid disease, diabetes, where you're at higher risk. And then there's a lot of lifestyle factors as well. So if you're a smoker, if you're drinking more than 2 standard drinks a day, you put yourself at increased risk. A huge one is obviously having a family history of osteoporosis. If your mum's broken her hip, or your granny broke her hip, then you're at higher risk. And age is probably the biggest risk factor, and also the age that you go through your menopause. So especially women under 40 who have a very premature menopause, or women who have a menopause between the age of 40 and 45 and have an early menopause, they are at higher risk.
So basically, pretty much everyone should be thinking about having one to see where they are.
Absolutely.
And I think one of the things that I want to get across as well is that you don't usually know that you've got osteopenia or osteoporosis. There's no pain involved until you've got a fracture. And by the time you have pain from your bones related to this problem, it's kind of like, the horse is already bolted. We want to get you way before that stage so that we can do something about it. And so if someone already has on their scan osteoporosis, is it too late? Can we reverse them back? Or is it like you can just make it a bit better?
Yeah. Look, I think if someone already has osteoporosis, the main thing that you're trying to do is prevent fractures. So yes, you may be able to partially improve their bone density. So say women went on to hormone treatment and particularly estrogen treatment, their bone density can improve within 2 years of treatment by up to 5%. But unless we're educating women about all the other things that they have to do, then that's all we're focusing on is increasing the bone density. But if that woman's balance is awful and she falls over, she's still at very high risk of fracture. So it's about the whole gamut of what someone can do to really protect their bones.
Yeah, absolutely. And so if we know some of our listeners are a bit younger, what can you do to make sure you lay down really great bone?
Yeah. So as I said before, it's when you are 25 or so, that's when you've reached your peak bone mass. So even people that have young girls, really encouraging them from a young age that they need to be very active, every day trying to be active in some shape or form, and making sure that they're getting enough calcium in their diet. So calcium is always best to come from a dietary source. For a postmenopausal woman, you're trying to be getting 1,300 milligrams of calcium a day. And then getting your vitamin D is very important to make sure you're absorbing that calcium from the gut. And vitamin D, obviously, we largely get it from the sun. It's in some food sources like fatty fish and egg yolks, but mainly it comes from the sun. And, if you think you're not meeting your vitamin D requirement, you would be best off to take a supplement of at least 1,000 units per day. Don't smoke. Don't vape, because you might end up smoking. Obviously, thinking about alcohol as well, as that is really a significant risk factor. So trying to limit within the guidelines, which is less than 2 standard drinks per day, a couple of alcohol-free days a week, and no more than 10 drinks in one session.
And do we know why? Why is alcohol affecting our bones? Do we know?
I don't know, actually. That's a good question. What do you think?
I don't know. Is it just maybe that if you're drinking too much, you're not, potentially making the other great lifestyle choices that
Probably.
perhaps go
Yeah.
alongside it?
I don't feel like going for a run. I had even more than one the night before.
Yeah, absolutely. Yeah, I don't know. I'm going to have to look into
Yeah.
that one. This episode is brought to you by my 16-week Rediscover You program, designed specifically for women navigating the challenges of perimenopause and menopause. If you're dealing with disrupted sleep, mood changes, or unexplained weight gain, this evidence-based program combines medical guidance, practical tools, and a supportive community to help you take control of your health. Women have reported significant improvements in symptom management of sleep quality and overall well-being. As an All About You listener, when you mention the podcast, you'll gain priority access for our next intake. Click the link in the show notes to learn more and join. I'd love to help you rediscover the vibrant, confident version of yourself. So Sarah, I know that you're a menopause coach as well as an alcohol coach. Do you feel like you would try and get someone or suggest your clients get their hormones sorted out as best as possible before they try and go down the route of sorting out their alcohol? Because then you're going to potentially have that kind of double whammy effect of anxiety being caused by, the hormones dropping off in perimenopause and postmenopausally, or do you just kind of work with people where they are? So if they really want to focus on alcohol, we focus on alcohol. If they're like, look, I feel like I've got all these perimenopausal symptoms and I'm not coping and I'm having hot flushes and all these things, would you get them to do that first?
Interestingly, there's a couple of rehab facilities in America that have said the most success they've had with female clients with addiction is when they've put them on HRT before they've taken them off the alcohol, because extreme PMS can lead to very severe alcohol cravings. And when women are in perimenopause and their hormones are fluctuating, there can be extreme experiences of PMS. So I just meet women with where they're at the time. There's a lot of talk now about menopause hormone therapy. There's a lot of talk about research that had come out all those years ago as being not actually true about HRT and breast cancer. Although, interestingly, I did interview a menopause GP not that long ago, and she said something that people don't talk about is that research was all, clearly debunked and made out to not be true. But what we know is that if you're on HRT and you're drinking alcohol, those two combined will increase your chances of breast cancer, because alcohol causes increased circulation of estrogen. Plus, you're taking estrogen in the form of HRT. And hormone-positive breast cancer is excess estrogen that's not being properly processed and metabolized by the liver, that is then being altered and back circulating around the body. And yet, I don't know a single woman who was told when she started taking HRT that she shouldn't be drinking alcohol at the same time. I don't know. Is that something that you talk about?
Look, I think the thing with estrogen receptor positive breast cancer, I think that is can be something that's really confusing to a lot of patients. And my understanding of estrogen receptor positive breast cancer is not that estrogen caused their breast cancer at all. So if just in really simple terms, a cell is normal, and a normal cell has estrogen receptors, progesterone receptors, dopamine, adrenaline, like all sorts of things that it has receptors for, and that's a normal cell. And as a cell becomes cancerous, it becomes more and more abnormal, and receptors in a way drop off. If you get to the point where you've got an estrogen receptor negative breast cancer. It means that the receptors that made it look like a breast cell, and it's become less and less and less like a normal breast tissue cell, and lots of its receptors have dropped off. And the reason that that's significant in cancer treatment is because we can manipulate that cell with that hormone, or by withdrawing that hormone. So it's not that the estrogen caused the breast cancer, but it's that you can afterwards manipulate that cell by using the receptor. So, in breast cancer, because we've got treatments that can attach onto like the Herceptin receptor, the estrogen receptor, that's why we're very interested in whether it's estrogen receptor positive or negative. And obviously, if you already had a breast cancer cell in your body, or you've got a small lump that's full of breast cancer cells and they've still got their estrogen receptors, and someone gives you a big dose of estrogen, well then your breast cancer cell is going to go yippee and going to like want to grow. But I think we have to be really careful that we're not confusing that with saying that estrogen is causing your breast cancer, because that is absolutely not my understanding of it. And I think, but on the other side of what you're saying is absolutely right. Alcohol is a big risk factor. And, if in some women there is an increased risk because they potentially already have some kind of small breast cancer that they don't know about. And that's one of the reasons with my patients, before we start, we always go and have a clear ultrasound, mammogram or MRI. So I know that we're not starting something that might cause a nightmare further down the line. But the reality is that, I think that sometimes we're scared of the wrong things. And, I think that on the whole, for the vast majority of women, menopausal hormone therapy, or HRT, whatever you want to call it, is incredibly helpful for so many parts of a woman's life. And it's absolutely a choice, of course. But I think that the reality is that, drinking alcohol is probably way more risky than taking HRT.
Yeah. And the Lancet, like the big medical publication, came out a couple of years ago, and they called for policymakers to ban advertising of anything linked to causing breast cancer, because they're seeing such an increase in breast cancer cases. And they named alcohol. They said, we're asking policymakers to ban the commercial marketing of alcohol because of its link to increased breast cancer. And yet nothing seems to change. It'd be very interesting to see if alcohol does go down the path of tobacco or not.
Yeah, I don't know. I sometimes think of it's so culturally ingrained in the UK and Australia, and I think politically, we have these very short election cycles. So would there ever be the political will to push it on? It's very interesting. What symptoms do you think of that period of gray area drinking? There's such an overlap between symptoms that you could put down to perimenopause, like the irritability, the anxiety, and the fatigue. How do you decipher whether it's your perimenopause or whether it's your drinking?
Well, it's probably both. And that's, the fact for so many women. And so for lots of women, what I find is when they remove the alcohol, it gives them the opportunity to see, well, what are my perimenopause symptoms actually like when I'm not dealing with mid-level hangovers for a lot of the week. And so it can be both. And so you can't tell unless you take that break from alcohol. And then you get to go, okay, so what is my sleep like? What is my anxiety like? What is my mood like? But all I know is that alcohol exacerbates all of the symptoms of perimenopause. And if they were at a 4 out of 10, if you're adding alcohol to the mix, you're probably making them an 8 out of 10. And so if we want to kind of be trying to reduce what some of those symptoms are, particularly hot flushes and things like that, then reducing or removing alcohol can be really powerful for that.
Yeah, and there's definitely very good evidence to suggest if you withdraw alcohol, it won't necessarily take them away, but you seem to have lesser symptoms. How long do you think it takes for the brain? So we have our 45-year-old woman, and she's a few weeks in. How long do you think it takes for the brain's reward pathways and dopamine levels to recalibrate to look like someone who hasn't been grey area drinking? Do we have any sort of research on that?
So when I did my coach training several years ago, the research was saying longer term to create full homeostasis back to our neurotransmitters after drinking, it can take over a year. But I see in lots of women that I work with, that kind of 90 days seems to be a really good amount of time to start seeing some balance in those neurotransmitters. But we've got to be careful because a lot of people do have cross addiction where they will stop drinking and then they swap alcohol for sugar, or they swap alcohol for scrolling. Or so we're just going to, be really mindful of that, because we do live in a world where, dopamine addiction is everywhere we go, whether it's scrolling, online shopping, sugar, gambling, porn, online gaming, all of the things, they're so easily available to us. So finding those simple ways to get effort-based dopamine. So exercise is great, cold water therapy is great, getting time outside in nature is great. And just, starting to find ways to create fun and interest and enjoyment in our lives that aren't relying on a phone or an alcoholic substance or food or whatever.
Yeah, I've had a few patients recently tell me that they've given up alcohol, but two of them started vaping, and they were feeling awful and so guilty about it because they were hiding their vaping from their teenage children, who they said in their own words they'd been horrified if their teenagers were vaping, and there they were vaping. And the other one was telling me recently that she was just compulsively shopping, just constantly buying things on Instagram at night. She said it's actually embarrassing. There's just parcels constantly arriving. What are your strategies to help work through that kind of boredom? Because I think that's what it is, isn't it? It's like doing something and getting a dopamine hit another way.
Yeah, and I think it's two things. So I think we've got to make sure that we're getting natural dopamine. Exercise. I don't know anyone that successfully removed alcohol from their life where exercise didn't play a part. So for me, I used to go to a body attack class on a Friday night at the gym at 5:00. And that was the thing I did instead of drinking. And it made me feel great. It was challenging. You're moving your body, you're getting the endorphins. And so effort-based dopamine is great in getting that exercise. And then it's, well, what am I adding in to my life in the evenings or with that spare time that I've got, whether it be, starting to look at online courses that I might want to do, or starting to think about some new hobbies that I might want to take up. And that's where it gets really interesting. And I see women go back to university. I see them go and start them in tap dancing classes or horse riding lessons or joining a choir or joining a hip hop dance class or whatever it might be, but starting to add in where we've taken the alcohol out.
What is sexual longevity? And what do we mean when we're talking about that? And why should women in their 40s and 50s be starting to think about it?
To me, sexual longevity just means, the continuation of sexual interest. And sex may look different as we get older. I think that there are different variations in terms of, your partner may have erectile dysfunction, and so maybe you're not having sex the same way. But just continued intimacy, continued exploration, continued interest in being close to someone, I think is important as we get older. And I think certainly everyone, not everyone agrees with me. Some people think that that's not important, but I just think that there's so many benefits to having that close relationship with someone. And it's very hard. We're in a world where we're surrounded by computers and phones, and we're on our devices all day. And but sexual health and sort of being close to someone is something that we can't mimic with all these devices in our world.
Yeah, absolutely. Amy, on this podcast, we've talked a lot about hormones and sexual wellness, but what are the other kind of lifestyle things that people really need to understand are also impacting their sexual wellness?
Anything that is good for your heart is also good for your sexual organs. So anything that's going to improve cardiovascular health, such as exercise, weightlifting, running outside, eating healthy foods, keeping your blood sugar down, keeping your lipids down, anything like that is going to be important and good for sexual health. It's interesting, in men, we know that the most common cause of sexual dysfunction is a vascular problem, a blood vessel problem, right? Like blood flow problem. And that's probably also true in women. Women just aren't as studied as easily. So we don't have as many metrics on that kind of blood flow in women, but blood flow is a huge thing. So work on your lifestyle, reduce cardiovascular disease risk, and that will help a lot with sexual health as well.
We seem to live in a very stressed world at the minute. Everyone seems to be busy
Yeah.
and everyone seems to be stressed whenever you talk to them. And I know that I'm guilty of that.
Yeah.
Do we actually have any firm data around stress and its impact on your heart health?
Not as granular and firm as what we would like, but I think anecdotally we see it is a big risk factor for coronary vascular events, and it doesn't help conditions like high blood pressure. And I think probably more work's needed, but there's not a great test for stress, and I guess it's increasingly prevalent in all of our lives. And so I guess for us as doctors, we should learn from our patients, right? So we're seeing people's lives literally every day change and take a different course. And what it's taught me as a kind of middle-aged dad is, really cherishing and spending the time leaning into the things that really matter. And part of that means, trying not to work too hard, and trying to take the time to balance, and that helps to manage what is a very stressful job, right?
Yeah.
I don't know how you manage that, but you've obviously done well with.
I've got very grey hair. Tom, is there any exercise that is too much or not good for the heart?
Yeah, I would say the really extreme forms of exercise, we do know that there's a J-shaped curve. And what we mean by that is if we do no exercise, the risk is high. And as we do exercise, the risk of events comes down. But the J-shape means if we continue to really go for really extreme, then we do see an increased incidence of things like AF, which is an irregular rhythm. And of course, we know that, really intense exercise and marathons would be one example where we do see a higher incidence of heart attacks. Does it mean that we shouldn't do it? Well, I think it's a personal decision. I think the absolute risk is quite low. And I think maybe those really extreme Ironman type competitions probably, if you're doing an ultra marathon lasting for 3 days, probably there's a small risk associated with that. But for most of these people, and I've got friends that are into that, and whilst I like health and fitness, the extreme stuff probably not for me. But, it's part of what makes them them. So I'm kind of relaxed that, people can make their own mind up. But yeah, I would say that too much exercise in that really strenuous way is probably not a good thing. And also the other side of that is, really intense bodybuilding and things like that is probably associated with its own potential risks. And
I have a couple of male patients who are a bit naughty and seem to take some supplements and things that's just safe for bodybuilding.
Yeah.
And a couple of them they have horrendously high blood pressure, and I just really worry that they're a heart attack waiting to happen.
Yeah.
Do you see sort of these bodybuilding types presenting with
all the time? Yeah.
And is that related to the steroids and things that they're taking, or?
I think it definitely is a risk factor for things like that you talk about. High blood pressure, we're going to have more sticky blood because the blood count goes higher. So we're talking about, obviously, injectable testosterone is easy to identify, but there's peptides and there's supplements, and they probably all have some form of exogenous testosterone. And I can understand, it's part of a lot of these men's, lives, and it's enjoyable. It makes them who they are. But, I can think of quite a couple of patients I've seen in the last few years that have had, sizable MIs. And one of them is very lucky to be alive, had this huge hole in his heart, presented really late. And I think the biggest thing for him getting over this heart attack was just readjusting to life. It's like, well, training was just everything for this guy. And so I kind of empathize and try and kind of personalize treatment. But ultimately, the patient has to make their own mind up. It's not our job to tell people what to do. It's our job to guide them, and then they would make their own decision at the end of the day.
What about cardiologists who take a much more, like there's some famous cardiologists based in the US who have kind of really, I suppose, spoken out about using diet much more aggressively to reduce the need for stenting and things like that. I don't know whether you've watched any of the documentaries or read any of the books like The Forks Over Knives and things like that, which really talk about staying away from sort of animal-based foods, and that you can reverse coronary artery disease by changing your diet to a mainly plant-based diet.
Yeah.
I just wonder what your take was on that.
I think that we can do better with diet, and I think that we need more data for these types of diets. And we're talking about really rigorously conducted scientific studies where people have a very strict diet. They're randomly allocated to you this diet or that diet, and we assess clinical outcomes. But until we have that data, I think the evidence for dietary intervention changing outcome is quite weak. And my approach is really, I try to listen to what the patient is telling me in terms of what they're trying to achieve. And ultimately, if that's the way that they want to go down, I would respect that. That's their decision, and I'll sleep easy. Ultimately, it's not for me to tell them. But I think that the key thing is, family history and previous events. If you've got a strong family history of heart disease, or you've had a previous heart attack, in my mind, diet alone is not sufficient. You may be lucky, right? But statistically, if I'm treating lots of patients, that we all are, that we're going to be doing them a disservice unless we're actually getting them onto the therapy that we know is proven to reduce the risk of heart attack. For an individual, they might get lucky, and that would be good. We want to prevent troubles, but ultimately, diet alone is insufficient to control risk factors for patients that are at very high risk. That's an important message.
What about strength training? Obviously, strength training, everyone's talking about, I think, two things: eating more protein and strength training. They seem to be like a nearly full-time job for women at this point. What is the connection between having strong muscles and doing strength training and bone health?
And bone. So if we think about the way that our muscles work together with bone, if your muscles are largely attached to bone, and so if your muscle's pulling on that bone, it's going to stimulate some growth. And generally, the bigger the muscle is, then the bigger the pull. So if you can give yourself some muscles, then you're going to actually help your bones long term. But it's also just about then, if you think that's probably going to help your balance too. And we now know that, the amount of muscle that we have is linked to how long we live. So if you think that, you're losing muscle as you age, which is called sarcopenia, there's that critical point that you get to, which if you tip over that and you've lost so much muscle, you can completely lose your independence. And if you think, well, if you're not independent, you're probably at high risk of falls, and then you're more likely to fracture your bones. So yeah, strength training is absolutely critical for a woman that has thinning of the bones already, but for all women really, then they should be thinking about doing some strength training.
And so then strength training and then balance as well, because I have to say, I don't know about you, but all of a sudden I realized when I was climbing over some rocks at the beach, I was thinking, God, when I was a kid, I could just jump from rock to rock and not even think it. And now I'm like some kind of cautious, anxious wreck.
Yeah.
I'm gonna like break an ankle. But it's like you don't notice
Yeah.
that it's suddenly kind of crept up on you and you're thinking, oh my goodness, actually my balance is not as good as it was. That is all connected because of course if you have these osteoporotic bones and you fall over, well, it's not going to end well in comparison to if you've got nice strong bones.
Yes, and you might have seen recently on Instagram, there's the little thread going around of trying to balance on one leg and kind of squat when you're on one leg, all those sorts of things to just try and test out your balance. There's all sorts of things, trying to stand on one leg when you're brushing your teeth.
Oh, my poor mother, I have her, my poor mum, who's in her 70s, and she's like, telling all her friends, my daughter says we have to stand on one leg when we're brushing her teeth.
Maybe you should tell her to do that while she's waiting for the kettle to boil, because she probably has a fair few cups of tea.
That's right. Well, also, she's very into craft, and I also make her say you have to sit on the floor and you have to just keep getting up and down.
Yeah.
Because when you do look at the people who live in those blue zones and who are really fit, a lot of the time they actually do sit on the floor, and they reckon it's that act of getting up and down and having quite strong thigh muscles that make a difference.
It protects them. Yeah.
I was chatting with a patient the other day, and we were kind of laughing, but it was serious. Her mum had fallen over at home and couldn't get up, and unfortunately didn't have her little necklace with her coal alarm, and her mum had lain on the floor for a few hours before anyone found her. And we were just talking about how frightening that must be whenever you can't get yourself up.
Yeah.
You know, that you're actually at
Terrifying.
the mercy of. And I think that really does make our generation go, okay, what can we do about this frailty thing?
Yeah.
Because, you know, I think being able to get in and out of a chair means that you can get up and down and answer the door or answer the phone and be sociable, or being able to get in and out of a car means that your family can come and take you out, and being able to get yourself up and down off the toilet means that you're continent.
Absolutely.
And, you know, lose your thigh muscles and basically you lose your independence completely.
Yeah. No, look, it's absolutely crucial. And I think that people like you and I have a real responsibility to women when we see them, that we impart this information. You know, I think that looking ahead to frailty and being in a nursing home is not an inevitable thing. It's entirely preventable. And the changes that you make now, you know, you have to do something that's sustainable for you, but you make a choice every day. But I think that's why, you know, it's such a privilege what we do. We can, you know, 100% change the trajectory of a woman's life by how we impart that information. You know, I don't know how many times I've seen people that just get told they have osteoporosis. They might get told to just have this injection that helps to build your bones. We'll see you in 6 months. But I don't think they're given that full picture of actually, this is likely what's going to happen to you. Things will likely continue to decline. You may continue to have a fracture in your future if you don't do all these other things. And, you know, someone's only going to take that on board if we impart it in such a way that they understand that it's completely critical.